And that's why the term addiction is so important. When we recognize something as addictive, regardless of the substance, regardless if it's a behavior, regardless of anything else, we're simply recognizing it's hard to get rid of.
Food Addiction is a podcast which explores the disease of food addiction and presents the solution. We interview professionals and counselors who specialize in the disease of food addiction, and we interview individuals who have successfully recovered from food addiction and discuss how they did it. Esther Helga Goodmans-Dotier was motivated to change careers after she recovered from food addiction by opening a food addiction treatment center and the IFACC School, the world's first and only sugar and food addiction counseling training, which offers a recognized certification. Check out the website for more information on obtaining this certification, as well as proven recovery programs at IFACCschool.com. Listen to these episodes as we discuss the problem and the solution around food addiction. Today on the podcast, we're excited to host Dr. Adrian Soto-Mota. Welcome, Dr. Soto-Mota.
Thank you. Thank you for inviting me, and thank you for having me.
Yeah, this will be great. I'm going to introduce you with your bio and get into some questions about your work and some of the work you've done in food addiction. Adrian Soto-Mota is an MD and has a PhD and is a clinical researcher at the Metabolic Diseases Research Unit at the National Institute of Medical Sciences and Nutrition in Mexico City, Mexico. He obtained his MD at UNAM, National Autonomous University of Mexico. It is the largest university in Latin America and one of the most prestigious institutions in Mexico, where he specialized in internal medicine at the National Institute of Medical Sciences and Nutrition. He is a specialist in internal medicine and human metabolism. He obtained his PhD at the University of Oxford and his professional certificate in data science. Currently, he serves as an internal medicine consultant and as a clinical sciences lecturer at the Monterrey Institute of Technology and Higher Education. His research interests are human metabolism, focused on ketone metabolism, data analysis, and evidence-based medicine. He is an active member of the American College of Physicians. So welcome again, Dr. Soto-Mota. We're going to get into your work, and I'm excited to host you today.
Thank you. Thank you again for the invitation. I'm always happy to talk.
Yeah, this will be great. Yeah. You have a very interesting combination of experiences in education. You're a PhD, you're a researcher, you practice clinical medicine. So talk about your work, what you do.
Well, as you already alluded to, I tend to wear different hats. On some days I wear a clinician's hat. On different days I am mostly a researcher. I'm also a teacher. I think, I like not having the same day every day. This is something that is not appealing for everyone. Some people like having a very established and predictable routine. I think I am happier when I have a variety in how my days and the problems I have to solve look like. So I enjoy all those aspects of my work. I enjoy teaching. I enjoy helping patients and clinical practice. And I also enjoy research. So I think that it's not lack of compromise with any of those. I think that doing research makes me a better clinician. Being a clinician makes me a grounded and down-to-earth researcher. Both things, I think, make me a better teacher. So I believe in balance.
Yeah, I'm sure you never get bored. There's a lot of variety there. And each one supports the other, it sounds like. Your lab is in Mexico's equivalent of, it sounds like, of the U.S.'s NIH, National Institute of Health, research facility. In the lab, different studies you do, mostly around diabetes, high blood pressure, autoimmune disorders. Talk about your work there in the lab, the research.
Sure. This institute is also gets to wear many hats. Perhaps that's also why I got the idea from. It's a hospital, first and foremost. It's a tertiary hospital, a reference center hospital for many different diseases in Mexico. So we are a reference center for autoimmune diseases, for transplants, for certain types of cancer, for metabolic related illnesses, and it's also a research facility, and it's also a school. So I think that, of course, I am able to wear all these different hats because my hospital has place for all these different hats. So I tend to, I am also part of the teaching program of the internal medicine specialization. So I oversee patients with residents whenever it's in my calendar. And I also teach them stats. And I also, for example, advise their thesis in Mexico. For earning your medical specialization degree, you have to make a research thesis. So I also help them with that. And I have a private clinical practice. But mostly what we do in our lab is focus on the metabolic aspect of very different diseases. And you won't find a disease that it's not, at least in some form, caused or affected by metabolic disturbances. In the end, it is true that our body is a network, is a system, and if part of that system is ill, the energy delivery system will play a role in either whatever broke that part of the system or in improving or worsening whatever is going on. So I tend to say that all diseases are, in a way, metabolical. This doesn't mean they are entirely caused by your diet, your lifestyle, an inborn metabolic problem, but it does mean that if you don't pay attention to metabolism, it's going to be harder to get clinical improvement in whatever you're looking at. So these Metabolic Diseases Research Unit focuses, yes, on the most well-known metabolic illnesses, but also we like to focus on the metabolic aspects for other diseases, because, again, this is placed in a tertiary center for many different diseases. We have the opportunity and access to patients with very different diseases. So that's why there are some studies on critical care patients or studies on transplant recipients or on donors as well. So it's part of the advantage of having such a multidisciplinary place and such a multidisciplinary lab.
Mm-hmm. I heard what we're going to talk about is most of the metabolic diseases that relate to, obesity and food use and food addiction and so forth. I heard in a presentation at a conference you spoke, you said lifestyle is the underlying problem associated with many chronic diseases. So we get to chronic disease. I'd like you to define chronic disease and then talk about what you mean by that.
Typically, and this is not a formal definition or anything like that, but typically we understand as a chronic disease as something that will be with you at least for a long time. There are chronic infections, for example, and yes, you can get rid of them, but it will take many weeks or months. Some diseases are lifelong diseases. For example, a good example is cancer. Many researchers now advocate to perceive cancer as a chronic disease, because even in those cases in which you cannot get rid of the cancer, people live with the disease for almost 10 years, for example. I'm sure many of your listeners are close or know of someone who lived with cancer for 7 years, 10 years. And this is, of course, a consequence of getting better treatments. This is also a consequence of improving the safety profile of many of those treatments as well. And even in those cases where the cancer was never cured or removed, it took a long time for the disease to cause someone's death. So I think it's fair to say that if you have a disease that lasts for 7, 10 years, it's fair to call it chronic, and it's therefore fair to bring this mindset into the way you analyze a disease, because it will change your goals, it will change your outcomes, your relevant outcomes. It will. This is also part of why, for example, there is an increasing interest in what people are calling patient-based outcomes, which is a fancy way of saying quality of life. I mean, all of us, regardless of how healthy or how ill you are, all of us are going to die. And that's why perhaps it's more important to have quality of life as an outcome and not necessarily, how much time someone survived with a given illness. So to go back to your question, chronic disease simply means a disease that will be with you for a long time. And there isn't a specific cutoff to say, after this duration, it's chronic and it's acute if it lasts less than that. There isn't a formal definition of time.
Yeah, we know that obesity can be a symptom of food addiction. Not everybody that is addicted to foods are obese, but this is a big part of it. So when I think of chronic disease as it relates to food addiction, I think of diabetes, high blood pressure, chronic illness related to carrying extra weight or obesity. And I had both of these when I weighed 200 pounds. Diabetes and high blood pressure. How often do you see patients that have these things, either or both, and are also overweight or obese?
Every single day I go to work.
Every single day.
That's business as usual.
Yeah. So, and this is one of the things that I'm wondering about with the medical community. You see it. You see somebody that, let's say somebody comes into you and they're 50, 100 pounds overweight. They have high blood pressure, diabetes. The doctors, it would be nice if they counseled you and said you need to change your lifestyle. And I saw your comparison of smoking and bike riding. That if they began to eat properly and eat whole foods rather than processed foods, would these things go away? In my case, they did. But what do you give them pills? Do you counsel them? What do you see there?
I think that different people will need different interventions. This is true regardless if you're thinking of an infection or if you're thinking of diabetes or any other disease. Part of the analogy between smoking and riding a bike is aimed at communicating intuitively why different lifestyle changes are or require different approaches. Part of what I was trying to convey there was telling a patient, why don't you ride your bike for 20 minutes every day? It's a lifestyle change, for sure. Walking with your dog is a lifestyle change. Setting your alarm 15 minutes earlier, it's a lifestyle change. All those things are lifestyle changes. However, they are intuitively different to getting rid from an addictive substance. So we tend, because we have this concept of lifestyle interventions, we tend to clump together things that are in fact very different. And that's why the term addiction is so important. Because when we recognize something as addictive, we are recognizing it's inherently hard to get rid of. It's not inherently hard to get rid of the time you set your alarm. It's not inherently hard to change which side of the bed you wake up on. And it's not, I mean, when we say something is addictive, regardless of the substance, regardless if it's a behavior, regardless of anything else, we're simply recognizing it's hard to get rid of. And getting rid from a nicotine addiction is very different than
walking your dog 20 minutes.
What you wear or anything else. So that's why, sure, everybody recognizes, patients, clinicians, college boards and institutions recognize lifestyle changes are super important. But we very frequently overlook that lifestyle changes are very different interventions and require very different approaches.
Mm-hmm. Yeah. Smoking being the addiction, that's a lot harder to get rid of than, say, waking up earlier or walking your dog, I think is what you're saying. You've done some work around the keto diet and written articles about it. Can you talk about the keto diet and how you would recommend this? It looks like maybe you've said that it helps diabetes patients, and I have a definition of a keto diet for the listeners. A keto diet, short for ketogenic diet, is a low carbohydrate, high fat diet designed to shift the body's metabolism into a state called ketosis. In ketosis, the body primarily burns fat for energy instead of carbohydrates. So,
sure. And it's not only something I've said, it's something that has already a good amount of solid evidence. And when people who live with diabetes adopt a ketogenic diet, in many cases, they can put it into remission. And even when that's not possible, they can get very good glucose control with less medication. So, which is not something to, sniff upon. I mean, it's relevant, even if you don't put it into remission, to require less drugs. This exposes you to less potential adverse effects. This costs less money. And this actually gets better glucose control than many of the things we usually prescribe. A ketogenic diet has also shown clinical benefits for many other different diseases. And I liked very much the definition you just used. There's a lot of debate on whether a ketogenic diet should be defined by a given amount of carbohydrates per day, or if a ketogenic diet needs to be defined by achieving or not high ketone body concentrations in your blood. I mean, however, I like the definition you used. I mean, what's supposed to do is to shift the main fuel your body is using. And I think that's intuitive, or at least for me now it's intuitive, that if you have a disease characterized by poor handling of carbohydrates, it could help to don't rely so much on carbohydrates. It could help to rely on something else. And if you do this in an early stage of the disease, you might be as lucky as to get rid of it entirely. I mean, some studies have shown that, or the way I typically explain this to my patients is that if you have a burnt out liver and pancreas and you send them on a very nice vacation, they might simply come back to work with renovated spirits, with, more than a good performance. So I think that even when remission is not something attainable for everybody, it's good evidence. There is good evidence that is an intervention worth trying. I won't say it works for everybody, but I think it's something with evidence good enough for being tried or promoted for people with diabetes.
Yeah. In our society, I recovered from my food addiction using a 12-step recovery program. There are treatment centers out there to treat this, just like alcohol and drugs. I would be curious to hear what you think of some of the go-to ways to help someone lose weight. I'd like to hear what you think about Ozempic and these other drugs typically used to control diabetes to help them lose weight, and also bariatric surgery.
Sure. I am an advocate for whatever works. And I don't have a I don't think there is real value in finding the best overall strategy, because in the end, I will have to find the best specific strategy for the patient that's in front of me. So there are some patients who are better suited for Ozempic or other weight loss drugs. There are patients who are better suited for bariatric surgery, and there are patients who are better suited for strict ketogenic diet approach. Now, all patients, regardless of which is their best personalized strategy, all patients have to eat. And therefore, if you are going to the OR to get a treatment for obesity, you still have to eat. You still have to be mindful about what you are consuming. If you are under prescribed drug for weight loss, you still have to choose what you put in your mouth. So I think that's because you have to do that anyway. I think it's reasonable to have that as your first approach. I think it's reasonable that food or dietary changes are the first intervention tried for people who live with obesity. And if that fails, well, then we look into different things. Low carbohydrate diets also are characterized or frequently involve foods that stimulate our own production of GLP-1, which is the substance at the center of the mechanism of action of Ozempic or tirzepatide or these other medications. So something I tend to say to my patients is, well, why don't we try it with your own GLP-1 first? You have GLP-1, you have to eat anyway. There are some foods that can improve your response and your production for GLP-1. You have to eat anyway. Let's try that first. And if that's not enough, then we think on different strategies. And the thing is that, this first approach is successful most of the time. So I have nothing against the other available options. It's just that because patients have to do it anyway, and it's cheaper than the other options, and it's safer than the other options, I think it's a reasonable first empirical step.
Yeah. If you've got somebody that's, 100 pounds overweight, and you say, hey, just, you need to eat, this whole foods diet, a nice balance of fat, protein, and so forth, which, is how I eat. If they're addicted to ultra-processed foods, if they're addicted to sugar, it's going to be hard to do that, right? They're going to have withdrawal and miss them, and maybe not be completely willing to do it. Is that right?
This brings us back to the difference in lifestyle changes. It's very different to try to change someone's diet if this person is addicted to ultra-processed foods or to some foods in particular. Not everybody with overweight has food addiction, but many times people who struggle with their weight have a food addiction. And it's very important to be able to recognize who is who, because then this will give us insight into which interventions are better suited for this person. Again, I am not a believer in the overall best strategy. I am a believer in the specific, individualized best strategy. And I cannot find that if I overlook that getting rid of certain foods will be harder for some of my patients.
Yeah, we're going to get into that. But before we do, I don't know that you, maybe you did address bariatric surgery. I've heard some horror stories of people where it's a very invasive surgery and they've had complications, and but some people do very well with it and lose weight and keep it off. Kind of look at Al Roker and some of the people that we see that are celebrities. There are times it sounds like you have recommended that and it's worked.
You will find success stories and horror cases of any popular intervention. I mean, this is true for bariatric surgery, for Ozempic, for chemotherapy, for antibiotics, for vaccines. You will find the best and the worst of every medical intervention. That's why it's so important to identify who are those more likely to be a success story than a horror case. That's in the end a clinician's job. And bariatric surgery is a good approach, and perhaps here I am biased and this is slightly controversial, but I am mostly a diet clinician. I am perhaps biased towards preferring or emphasizing diet over other interventions, but there are some studies that suggest that most of the physiological effects we observe in patients undergoing bariatric surgery are already there the morning of the surgery. And this is because no one arrives at the OR without previous interventions. All, worth their salt bariatric surgery protocols involve mental health support, dietary advice, physical activity guidance, and the surgery. So it's the knife itself, it's not the only intervention. And many studies have documented that the physiological changes we know are observable in someone after surgery are already there before the surgery started. So again, if a good amount of the effect is independent of the actual surgery and it's entirely attributable to lifestyle, try lifestyle first.
Right. Try to make changes first. And they've tried things. And this is sort of maybe the last stop. Here, we're going to take a shift here and get into some of the most interesting work that I've read. And I had watched your lecture at the conference in London. We're going to talk about that a little bit later. But your work, the science of it is pretty heavy, pretty intense. And for those of us who are listening that don't have PhDs and aren't science people and can see dots on graphs and kind of draw conclusions, I think it's important to kind of keep it as simple and common man as we can. But you made a very important statistical observation from your study that you talked about at the conference, and I'd like you to talk about this, that binge-eating disorder, which is a psychological disorder currently in the DSM of the American Psychiatric Association Diagnostic Statistical Manual. It's in there as a psychological disorder. Food addiction as a substance use disorder is not in there. And the study I'd like you to talk about is the difference, the similarities, yet there are differences in the two. That was the most critical thing I think that I saw, and I don't want to steal your thunder here. I want to hear what you say.
You made a very good summary, and perhaps the points I would emphasize are, as we already discussed, it's important to have a concept, an officially recognized concept that tells clinicians which patients are more likely to find it harder to implement lifestyle changes, because their behavior is inherently hard to get rid of. In other words, is an addictive behavior. We should remember that all illnesses are, and their definitions are arbitrary. Why is diabetes, your glucose above 126 and not 123? Why is blood pressure, high blood pressure above 140 and not 160? Why is, we have made cutoff points and boxes and definitions for many different diseases. And the fact that we have one existing or officially recognized disease does not mean it will still be an officially recognized disease in a century. And of course, we shouldn't be so naive to the point of thinking that we already finished discovering or defining new diseases or new ways of characterize a disease. That said, one of the other analogies I used in that talk is, imagine we lived in a world where we didn't know yet that diabetes and hypertension are different illnesses. We would see that very frequently high glucose coexists with high blood pressure. We would see that people who have one very frequently have the other. We would see, if we follow them in observational studies across time, we would see that they predict similar outcomes. We would see, in other words, we could be easily confused by whether it's the same thing or two manifestations of the same thing or two different things. So I use this analogy to try to explain why intuitively lots of what we conceive as binge eating disorder could have food addiction under the surface. Why? Of course, people with binge crisis or binge sprouts very frequently will have food addiction. And why? You could think they are the same thing. Part of the objective in our work, and we're drafting the manuscript actually, involves making an argument for explaining how both things could be true at the same time. That very frequently, people with binge eating disorder score high in food addiction scales, vice versa, of course. However, how there are some cases in which you can be high in one but not in the other, which is when you can then clearly see that two things are not the same thing. We have people with diabetes who do not have hypertension. We have people with hypertension who do not have diabetes. And that's why we accept that even when very frequently they go together, even when very frequently they look similarly, they are different things. The data we have so far supports that binge eating disorder and food addiction are a case comparable to that analogy.
Yeah, so they're very similar. There's overlap, but there are very important differences, and that's the key thing, is that you can be a binge eater and not necessarily a food addict. You can be a food addict, not necessarily a binge eater. That they are separate. And I think that's the biggest thing I got out of it.
It's as important as that difference is crucial, because to go back to the analogy, is as expecting that my patient's blood glucose will go down because I gave them blood pressure medication, yeah. Right? So that's why the difference matters.
Yeah, the screening techniques you used in this data, in this study, was two different ones. It looks like Yale Food Addiction Scale, and that is a self-reporting questionnaire that asks individuals the extent to which they experience problematic patterns of ultra-processed food consumption, which cause substance use experiences listed in the DSM. And that was developed by Ashley Gerhardt. And then you have another screening tool called CRAVED, and you can describe that if you want. But talk about your screening tools. I can talk about the acronym CRAVED if you'd like, or just I'd like to hear how you use the screening tools to come up with the differences in binge eating disorder and food addiction.
Sure. We have more than one objective in this particular study, and perhaps it's useful to explain why, if there was already a screening tool, people felt the need of developing another. And YFAS is the most studied screening tool for food addiction. It's it's
Yale
already
Food Addiction Scale. Yeah.
in its second edition. However, it's hard-ish to implement because it's a long questionnaire. And in research studies, you already burden participants with tons and tons and tons of questionnaires. So if there is an easier way of getting the same results, that's valuable. CRAVED is also a screening tool that only consists in 6 points that are presented or developed with the characteristics of addictions and addictive behaviors, one for every letter. And because it's only 6 points and not 20 questions or 16 questions, it's easier to implement. Now, a parallel objective in this study was to validate CRAVED in Spanish. Because very frequently, because all these instruments rely on language, there are meaningful language differences. Sometimes within the same language. For example, it's like the pants versus trousers between the US and the UK, or it's very frequently you can find people who speak the same language but understand the different things. And a parallel project or a parallel objective in this project was to to translate CRAVED. For these, we were helped by native speakers from Spain, native speakers from Mexico, translating the same instrument. And then you measure that it measures what it's supposed to measure in actual real world patients. So that's what we did, because you also want to compare that the Spanish version behaves similarly to the English version. And even when you would assume that a good translation should achieve that, it's something you actually have to test for. It's not a good idea to simply assume that because people agree on a translation, it will behave similarly. So those were the two objectives. But at the same time, we applied to our participants, we asked them to undergo a binge-eating screening tool, precisely to see if there were cases in which people scored high in the binge-eating screening instrument, but low in CRAVED, or vice versa, because this would be an argument in favor of they actually being separate entities. So that's a summary of what we did in our study. We did, we did other mental health instruments or questionnaires, but mostly as a quality check, as a quality control. But the main idea was, okay, let's see if this behaves as robustly as YFAS, and at the same time, if this allows us to detect people who score high in one, but not in the other, between the binge-eating and the food addiction questionnaires.
Yeah, CRAVED, the screening tool, and I'll explain to the listeners the acronym CRAVED, CRAVED. C is for compulsion, or powerful urges to consume. R is for reaching for more, increased tolerance and need. A is activities neglected, ignoring what you once valued. V is for volume, having more, eating more than you intended. E is for exclusion, or eliminating the substance causes withdrawal. And then finally, damage. Despite awareness, the use continues, negative consequences, as we say. So these are all evidence of, food addiction, binge eating disorder. You say in your study, our goal was to see if binge eating disorder was different and separate than food addiction. And it sounds, just the conclusion was that it is, right?
Yes. I mean, again, it's not a finished project. We're finishing to draft our first draft. But yes, our data support that notion that despite being similarly looking entities, they are separate diseases.
It's important, yeah. Let's shift over to the conference itself. In May of 2024, you attended the International Food Addiction Consensus Conference held in London. Many PhDs were there, including you. Professionals gathered and reached a consensus. One of the purposes of the conference was to agree that not only foods, but specifically ultra-processed foods be recognized, just like alcohol and drugs, in the World Health Organization, WHO, the International Classification of Diseases, ICD, and eventually the APA's American Psychiatric Association's DSM, Diagnostic and Statistical Manual of Medical Disorders, a mouthful there, as a substance use disorder like alcohol and drugs. So as a result of this gathering, a consensus statement was signed, and you signed it as well. Talk about the conference and what it meant to you. What did you learn? What do you think the significance was?
Sure. I mean, the consensus for a conference perhaps makes it sound as if all the work was done at the conference. And I really have to highlight that this was months of work before the conference. So this was a fantastic effort because you can have endless discussions on where a word is placed in a paragraph. So it's very hard to have people from very different parts of the world and academic backgrounds arriving at a statement they feel comfortable with. And understandably or intuitively, this takes months. And the London meeting was really to, make the final details to the actual text or statement, but also to plan the steps ahead after arriving at this consensus. So I think that looking back at it, it was a great meeting because it made me hopeful we're actually going to make it happen.
You think it will? You think it will happen?
Yes, I think it will. I think it eventually will. Perhaps not with our not exactly as we imagine it, but I think it will. And it was very motivating, intellectually stimulating to see people with very different backgrounds. And these are people who come from, for example, who don't agree on everything. Like this is people who disagree on other topics and who have opposite opinions on other topics, but can agree on something like this, which is very important. I think that, on a more social reflection, nowadays we're used to everything being polarized. And we are used to getting the two opposite poles of every single debate. And it was also refreshing to see people who disagree on many things agreeing on something as important as this.
Coming together. There were 40 professionals that signed this consensus statement. So very important work. And I hope it gets into, means a lot to the advancement of recognizing food addiction and having insurance pay for it, and realizing that a lot of the chronic disease is related to what we eat. You have said in other podcasts that you were an overweight kid, right? So you have a personal experience with carrying extra weight, right?
Yes. Mexico has a huge problem with childhood obesity. Very frequently, we rank first in the world with childhood obesity prevalence. And I was a stereotypical Mexican kid in that regard. consumed lots of soda when I was a kid, lots of pastries, lots of highly ultra processed foods. Actually, in a decade at a time where we weren't aware of many different substances we are aware of. For example, I mean, I'm sure my consumption of trans fats as a kid was huge. What was scandalous, and of sugar as well. And I think that this helps me connect with my patients, helps me, I understand the struggle of craving something it's not good for you. And I mean, in today's world, everybody has been exposed to suboptimal food quality. And regardless of where you live, of how strict your parents were, and however, not everybody understands the struggle, the personal struggle of fighting your will because you crave something it's not good for you. And this has allowed me to share things I found useful with my patients. This has allowed me to detect when someone can or may struggle with making dietary changes. One of the most frequent questions the first time I meet a patient is, what's your favorite food? Forget about health statements, forget about everything. What's your favorite food? What's something you can eat and eat and eat without getting bored of? And I think that, I mean, nowadays my weight is healthy, but I totally see how my brain developed in an environment with ultra processed foods. My brain didn't change. My weight did. My liver function did. My many aspects of my physiology changed when I lost weight, but my brain, even when of course, I mean, I have more capacity to control what I eat. Mm-hmm. That's for sure. However, it will remain the brain of someone who developed.
Who's an addict? Do you think you were a food addict?
I think yes. I think it's a fair statement. I mean, it's hard to make a perfect recollection of how my brain worked as a kid, but I remember finishing the jar of cookies, right? And for example, something that makes me think I definitely was is I do remember myself eating more of something without actually enjoying it. So just for the sake of eating it, right? Like it's not. I just kept eating cookies or ice cream, or I kept drinking Coca-Cola, even when I was not enjoying it very much. And I think that's very characteristic of addictive behavior.
Yeah, for sure. And I had the same experience. And, addict brains, they say, you're once an addict, always an addict. But if you can change your lifestyle, you can become healthy, you can turn this around. And you mentioned the obesity among children in Mexico. We have that problem in the U.S., and it's getting a lot of focus in the U.S. And so I think we'll see some changes in this. But what would you say about, I have one more question after this for you, but what would you say about the obesity crisis in Mexico, and what the solution is, if there is one?
We haven't even seen its true consequences. On a separate project, this is a collaboration between my lab and epidemiologists from Imperial College. We observed that during the last decades, the prevalence of people with obesity, but without other comorbidities, increased. And this may be counterintuitive, but there are two plausible explanations. Are we getting better at preventing these other comorbidities? Or maybe it's simply that because our population used to be so young, people with obesity haven't had enough time to develop. those comorbidities. And that's definitely the truth. That's definitely the truth. We had for decades such a high prevalence of childhood obesity, who were protected by their youth and by their physiology, by their youth, basically. We're starting to see the increment in these other obesity-related comorbidities that haven't even finished rising.
Yeah. As they get older, you're saying that it's in the children, and as they get older, they're not going to get away with eating like that any longer.
Exactly. So in our data, when you analyze, okay, if we are getting better at treating comorbidities, we should see the same thing of more people with obesity without comorbidities in people above 60 years old. I know, we don't see that. It's definitely only in young adults. And the thing is that they haven't been living with obesity for long enough. And as they age, they start developing the first, the second, the third obesity-related comorbidity. So that's what I mean when I say we haven't even seen the true consequences of that childhood obesity epidemic. Mexico is still a country with a young population. We are expecting that within the next 15 years, the amount of elders will double. And we haven't even get to the point where we can say, okay, from here we expect the prevalence of all these diseases will go down. We're not even there. I think we will be there in the next 10 or 15 years.
Interesting. Very different than the U.S. A final question, and thank you. This has been great. A great episode, and I appreciate your time. You've done the research. You've been in the medical field treating patients. You have personal experience with obesity as an overweight child. What would you say to the person out there who is residing in Mexico or any place in the world who has a chronic disease? They have high blood pressure. They're carrying 100 pounds, 50 pounds of extra weight. What would you say about food addiction?
I would say two things. It's not your fault, but it is your responsibility to solve this problem. And the second thing I would say is stay optimist. It's impossible to improve something, to engage in the mental effort of changing something, if you stop being optimistic about it actually, being able to improve. People who struggle with weight have tried many different things to lose weight. I haven't found someone with an excellent of 40 pounds who hasn't tried at least something, at least once. And the fact that they still have an excellent of 40 pounds means it was not successful. So understandably, this causes frustration. Understandably, this causes pessimism. This causes self-deprecation. This is understandable. So that's why I emphasize stay optimistic. It can get better, and it's not worthless. It's not irrelevant if you are 65 years old and haven't lost weight. It's not only for people who are young adults. It's not only for people who already have diseases or for people who don't have diseases. I think there are tangible benefits in trying again, and there are tangible benefits in partial success. You don't need to go back to your, juvenile weight. There are tangible effects on losing 80% of your target. Mm-hmm. There are tangible effects of simply changing your food choices. And there are, it's not your fault, but it is your responsibility, and stay optimistic about it.
Yeah, I love that. We may have that be the title, because once you know what's causing it, whether it's, your addiction to cookies or pizza or chips or whatever it is, once you know that that's it and you've got a problem with it, it is your responsibility to do something. Now, for me, it was 12-step recovery. But some people may lose weight on Ozempic or bariatric surgery and they keep it off, and that was their solution. But it is our responsibility. It's a personal responsibility. The government doesn't do it for us, right? So.
Absolutely. And this is true for many different problems. Lots of the things we have to face or we struggle with were not caused by us. It's part of the circumstance we developed in. However, no one will solve it for us, and therefore it's our responsibility to get it solved.
Right. Would not be a victim, but just take responsibility for our health, Yeah. So it's very important if we want to live longer.
Absolutely.
And be healthy.
I tend to say that the idea is to die young as late as possible. So that's the goal. It doesn't matter what age that is, just die young as late as possible. And it doesn't matter if you start that project when you're 60, when you're 20, mm-hmm. It's still beneficial.
66.
Yeah.
66,
absolutely.
Yeah. Healthy as I've ever been. So, Dr. Adrian Soto-Mota, thank you for joining me today. I know Esther is going to love the podcast, and our listeners will as well. It's been very, very informative and a great exchange. So thanks for joining me today.
Thank you for having me.
This is the Food Addiction Podcast. We hope you enjoyed the podcast and learned more about this disease. We hope you will rate and write a review on this podcast and share it with others. If you or someone you know is suffering from the disease of food addiction, there is a solution. The various food addiction recovery programs are available and listed on the website, theinfactschool.com. Or if you would like to know more about how to get certified in treating food addiction, the school is accepting applications now for its next training beginning in September 2023. Go to theinfactschool.com. That's INFACT school.com to learn more.